Today, we're going to talk about an interesting condition as well as it is very important clinically as well as theoretically, which is known as Neurologia Cefalea. We'll be discussing the primary headaches, particularly under this term. Basically, when I use the word of primary headaches, I'm referring to the headaches which are not as a result of any physical disability that the person has or any other systemic illness that the person is suffering from. For instance, people suffering from hypertension, and when they're not diagnosed, they usually present to you in the outpatient department with the symptom of headaches. So when I use the word primary headaches, we are referring to the headaches which are basically originated due to the neurovascular disabilities of the central nervous system. Over here, when we are considering these headaches, we have the most common of them are the migrainous headaches. Then we have the trigeminal neuralgias that are again resulting in the conditions of headache, as well as some of the other conditions which can also be regarded as the primary headache condition. The history taking in these particular cases of the primary headaches, once you have diagnosed that this person is suffering from a condition of a primary headache, particularly over here, we must know how to take the history, and what points we are going to focus on is again very important. Migrainous headache is the most common kind of the primary headache that we'll be discussing over here. Almost 15% of the females, and on the other hand, we have 6% of the male population that are affected by the migrainous headaches over here. So it's a very common condition, and regardless of the fact whether it is common or uncommon in a particular area, we must know how to make a correct diagnosis, how to differentially diagnose whether this particular person is suffering from a migrainous headache, and we have to even distinguish the patients of the TTH, that is the tension type headache that we usually come across. So these are the main focus points that we'll be discussing over and over when I'll be giving you the particulars and the definitions and explaining thoroughly regarding the migrainous conditions over here in this particular lecture. Now, the criteria for the primary headache disorders has to be fulfilled when we put any kind of the headache conditions over here under this term. And over here, we have the migrainous variety. From this particular term, you must be well versed with this condition, that it's basically a throbbing kind of a headache. It's recurrent in its nature, it's episodic in its nature, and again the symptoms are also associated with some sort of neurological disability as well. So these are the major highlights when we diagnose a person to be suffering from a migrainous kind of a headache. We must know that this is a criteria that he or she must be fulfilling. The nature of the pain is very important, the nature of the headache is very important, and again, one of the things that we have to focus on is the triggering factors. Triggering factors are always present when we have these patients of migrainous activity or having these symptoms that are quite similar to the migraine. We have two major categories of the migrainous headache. We have a migraine with aura, and on the other hand, we have the migrainous headaches without aura. Aura is basically the state or the sign and symptoms that the person feels when basically the major primary headache hasn't really started in that particular person, but he or she might feel dizziness. Vertigo is one of the symptoms that the patient might experience in this phase of aura. Then the patient might complain of seeing flashes of light. Extreme nausea is another condition that the patient might be suffering from. So these are the particulars, or this would be the particular history that you would be focusing on. You'd ask the patient whether he or she suffers from some sort of these neurological disabilities, seeing flashes of light, photophobia or phonophobia. Again, these terms have to be very clear to you. From phonophobia, it's basically, we mean that the person's triggering factors are related to the sound activity in the environment. So this is one of the condition, and this can be one of the triggering factor over here. And on the other hand, a lot of people give you the history of photophobia or photosensitivity, and that might be the primary triggering factor in the other people. So it's basically depending upon person to person, and it varies in all of the individuals. So it's not a hard and fast rule that we'd be focusing on over here. And we must focus on the fact that the triggering factor has to be highlighted when we take the history in detail. Past history is again very important over here. So you would ask if the patient has ever had any kind of this episode in the recent past, or any kind of episodes of nausea and vomiting that were associated with this kind of the headache that he or she is complaining of. Again, family history is very important. Migraine runs in the families. So it has the genetic association, and we must rely on this fact that we'd ask for any other person from the parental content, or any siblings that might be also suffering from this kind of the migrainous conditions over here. So these are some of the points that you'd be focusing on. The drug history is again very important. A lot of toxic effects of the drugs on the chronic basis over a period of time, they exhibit as very severe headaches. So you'd ask for the drug history as well, or any sensitivity and allergic conditions that the person might have suffered from after taking a certain kind of a drug. So this is again very important that you'd be focusing on the drug history, family history, past history. History of presenting illness has to contain all of the points that you focus on. Usually, even when you take the history of pain, even elsewhere in the body, you focus on the exact location of the pain, the intensity of the pain, the onset, whether it was a gradual onset or whether it was a sudden onset that occurred in that individual, and then the complete duration of the pain. These episodes of, if it is episodic in nature, we can put it in the category of migraine. So it's sometimes even the only distinguishing factor when we have patients of tension type headaches and we want to distinguish them from the migrainous headaches. The only difference sometimes lies over here that the people who are suffering from the tension type headaches do not have the associated symptoms of nausea and vomiting or blurred vision that we usually observe in patients of the migrainous headaches. So this is the complete history taking. You take the history in detail, and you'd also focus on the move on to the physical examination of the individual. Usually the vitals would reveal a normal study in these patients of the migrainous headaches. And as we even saw in the case of Bella, that she didn't suffer from any kind of hypertension, and her pulse rate was a slight raised pulse rate. And other than that, there were no positive signs even in the history of Bella that we studied in the, or when we looked at it in the case study. So these would be the physical findings, and when you carry out the neurological examination, that would not even reveal any positive signs. So this is that you have to focus on, that the person is not suffering from any kind of upper motor or low motor neuron lesion, because that is going to point out towards some organic cause of the headache in that case, if the person is suffering from some serious disability, neurological disability as well. So neurological examination has to be carried out in detail over here, and the vitals are the mainstay of the focus when we carry out the examination over here. And that is going to highlight whether the particular person is suffering from a migrainous headache, or either we have the tension type headaches. So what is the characteristics of a tension type headache? When the patient usually reports to you with this tension type headaches, it's a belt kind of a phenomena or a constricting phenomena occurring band-like projections around the head. So this constricting force is felt by the individual, and this is the particular wordings that he would usually give you. Even it can occur at the back or at the side of the head, and that is the usual site that is affected. How do we distinguish between the migrainous headaches and the tension type headaches is again very important. First of all, obviously, the history would reveal a lot of important factors. And as I've already focused on the fact that the migrainous factors or the migrainous headaches are usually associated with nausea, vomiting, or either it can be the blurring of the vision that usually observe in these individuals. So, the tension type headaches are not associated with this kind of associated symptoms, and usually they're isolated in their nature. It is a gradual onset of the pain that occurs. It can be of any nature, either a consistent pain or even it can be the throbbing kind of headache that is observed in these tension type of headaches in the patients. So the treatment is quite distinct in both of these entities. Having the right diagnosis is very important. Amitriptyline is one of the drugs that can be used in both of the cases. So if it's a confusing case, you can always resort to giving the amylin or amitriptyline in these patients. Then we have the patients with the trigeminal autonomic cephalgias. It can be again associated with any kind of external factors that are influencing the trigeminal nerve, and that is again the same pathway that is followed by even in the cases of the migraine. It is going to involve the trigeminal nucleus, and along that pathway, it is going to enter the thalamus and the nucleus ceruleus. It is going to affect the retroventro-medullary pathways as well as the pathways inside the brainstem. All of these pathways inside the central nervous system are affected when we are discussing the primary sort of headaches. The triggering factors are quite different in all of these cases, but the mechanisms and the underlying pathologies are quite similar. Then we have the miscellaneous group of primary headaches, and we can include the headaches that are associated with cough or exertional activities, and they are sometimes sorted down in this individual group of primary headaches over here. So these are the conditions of the primary headache disorders, and over here we went through the different differentials that we might have when we are expecting that this particular patient is suffering from a primary headache. We have ruled out the other systemic illnesses over here, and we want to focus on the fact that either the patient has some sort of an organic cause towards the development of this headache condition, or it is a primary state of the headaches in these individuals. So this is what we're going to focus on over here. Now, considering migraine as an individual entity, we must know that we have the different types over here. We have migraine without aura. So the patient would not have the symptoms of aura. He would not see the flashes of light, the different colors that the patient, even in some patients, they usually give you a history of seeing a particular color before the migrainous activity is started on in the central nervous system. So this aura that can be associated with nausea, or even it can be severe vertigo in a lot of individuals. So when it is missing, and there is a gradual onset of the migrainous activity, that is something that you have to educate the patient towards. In patients where we have migrainous activity with aura, we can educate them very importantly. We can give them the education that before when there are symptoms of aura's condition, they have to take their medications in time to prevent the migrainous activity to be started on in the central nervous system. So this education is quite simple in patients where there is this aura episode which is present in the individuals. When it is absent, obviously, there is going to be a gradual onset of the migrainous activity, and still you can take steps or preventive measures to stop the development of the migrainous activity in these individuals. We have migraine with typical aura. When I use the word of or the term of typical aura, basically I'm referring to nausea, vomiting, vertigo, and all of these are usually the associated symptoms towards the migrainous activity, and they are basically more recently reported towards the doctors. Typical aura with headache it can be typical aura without headache. So even in a lot of individuals, the person would have the migrainous activity, but he or she would not suffer from the headache. Instead, he would just complain of extreme vertigo or extreme nauseous activity, seeing flashes of light, and in a lot of conditions, they're not associated with the migrainous activity or the headache, which is the primary symptom in the migraine. So detecting these cases and diagnosing these cases would be very difficult, because usually the headache would be absent in these particular individuals. Now we have the other individuals in which we have migraine with the brainstem aura, and the brainstem conditions would be seen in these individuals. Hemiplegic migraine. Now this is a term which is specifically used for individuals in which usually the person suffers from hemiplegia. Hemiplegia is when one side of the body is affected and there are symptoms of paralysis or symptoms of stroke that are frequently seen in these individuals. So it's kind of a very horrendous condition, and usually it gives you the clinical picture of stroke. The person would be suffering from hemiplegia, and maybe if there are some associated symptoms, for instance, you have a patient who's already hypertensive, so the physical sign and symptoms and the vitals would be positive in this particular case in which these conditions of hemiplegia occur along with this conditions of migraine or the activity of headache that is taking place in the individuals. The familial hemiplegic migraine, so that would be basically diagnosed when the person is also giving you a history of the genetic considerations in the family that can be seen in the either the parents, the mother or the father, or it can be even seen in the siblings. So this is a positive family history. If that is present, then we can consider that the patient is suffering from a familial hemiplegic migrainous condition over here, which is also abbreviated as FHM. We have two major categories for this. This is the familial hemiplegic migrainous condition type 1, and then we have the type 2 of this activity, and then we have the type 3. Depending upon the different set of signs and symptoms that the patient is suffering from, it can be a familial migrainous condition with aura, without aura, or the person might be also suffering from the neurological disabilities as well. So depending upon the sign and symptoms, we have categorized these genetic conditions into three major categories over here. The sporadic hemiplegic migraine would be in a patient in which there is no family history, no positive family history is found, and the patient is suffering from the migrainous activity over here. So still, we can diagnose depending upon the classification and depending upon the sign and symptoms and the particular criteria. If the patient is fulfilling that particular criteria, then we can just classify that, or we can just diagnose the person to be suffering from the migrainous activity. So this is the particulars for the sporadic hemiplegic migraine. Then we have the retinal migraine. So when I said that the patient might be giving you the sign and symptoms of seeing flashes of light, or it can be even certain dark spots in the visual field, then the retina is also affected over here, and these are the set of sign and symptoms that the patient would be giving you. The patient can also complain of seeing floaters in the visual field. These are basically the blind spots which are floating either on either side of the visual field. It can be the right side which is affected, or either it can be the left side. Usually it is the side on which the person will be also complaining of the headache. So this is a particular category in which the person has the retinal sign and symptoms as well, visual sign and symptoms, as we can even term it as. Then we have another category, which is the chronic migrainous activity, and then we have the complications of migraine that you usually see in the individuals. So depending upon the chronicity of the symptoms, we can either say that the person is suffering from an acute category of the migraine, or either the person can also suffer from the chronic condition of the migraine. It has to be an episodic field of the migrainous activity over here. It has to be the recurring episodes that is how we're going to diagnose that this is basically distinguishing it from the tension type headaches or the trigeminal neuralgias on the other hand. The complications of migraine would be when we have the status migrainosus, we have the persistent aura without inarction. So the person doesn't have the headache and still he's suffering from that persistent nausea, vomiting, or even the vertigo and dizziness. And these are the complications that are quite persistent over here. It can be migrainous in action. And then we have the migraine aura, which is again giving off the triggers towards the seizures. So this is again very complicated condition in which we have a patient who was diagnosed with the migrainous activity and then he presented to you with seizures. Either the grand mal, or it can be the tonic-clonic seizures, or it can be the partial seizures, or it can be the petit mal seizures. Whatever the type is, usually you encounter these patients who have been already diagnosed or are on treatment of the migrainous activity, and they usually present to you with this triggers of seizures as well. Then we have a category which is termed as a probable migraine. So in this kind of a category, in which you are quite confused whether you can diagnose it with surety as the person is suffering from, or you can even start off with the treatment and the person is responding towards the treatment in a positive way. So you would categorize the patient to be suffering from a probable migraine over here. We have probable migraine without aura, and then we have another category which is basically the probable migraine with aura. The episodic syndromes are associated sometimes with the migrainous activity, and we have the recurrent gastrointestinal disturbances over here. So usually, as I said, it is also associated with nausea, vomiting. So it can be associated with the GI disturbances, including the diarrhea, recurrent diarrhea, or any stomach burning or epigastric burning that the patient usually has. So these are the associated symptoms or the associated syndromes along with this particular condition over here. Cyclical vomiting syndrome is associated with it. Then we have the abdominal migraine, in which the person basically complains of abdominal pain as well, associated with the headaches. Benign paroxysmal vertigo, and then we have the benign paroxysmal torticollis, in which we have the spasms of the neck muscles. Torticollis is basically a term which is used for the spasm of the neck muscles, and in these patients we usually confine them towards torticollis, as well as the patient would be giving you a history of migrainous activity as well in this particular patient. So we went completely through the different types and how do we basically divide this syndrome of the migrainous activity. There are a lot of websites out there that you can even visit. We have the American Society, which is working towards educating people towards this migrainous condition. We have a website, which is the akinet.org, which is working particularly in educating the individuals towards this migrainous activity, and how can they basically prevent the development of this migrainous activity. Lifestyle modifications are very important and very particular over here. A lot of non-pharmacological techniques have basically prevented the development of migraine in the individuals. It can be the practice of yoga, it can be the biofeedback conditioning methods, and it can be even the hypnosis, which is working quite positively in patients of the migrainous activity, and sometimes they are reverted from the pharmacological treatment towards just the non-pharmacological techniques of preventing these migrainous activity in the individual. So educating the individuals towards this condition, why does this occur in the particular patient, what are the triggering factors for that particular individual that are to be highlighted towards the patient, and even the patient himself can take preventive measures to basically avoid such environmental conditions which are basically causing him or her to this migrainous activity. So So this education is very important for these particular individuals. What is the pathological basis behind the development of this migrainous condition? We'll be going through the basic pathogenesis over here. So the brain is basically bathing, or it is the protective shells are basically the dura, the pia, and the arachnoid matter. These are the protective coverings of the brain, and these are basically the meningeal layers that we usually resort to. These meningeal layers have their blood supply, and as you can even appreciate over here, the cortical regions or the occipital regions, they are all protected through these layers of the meninges that are present out there. So the hypothalamus, as you can even appreciate over here, we have a thalamic thalamus, which is again very important. We have these different tracts, namely the contothalamic tract that is present, and then we have the dorsal raphe nucleus. As you can appreciate, we have the locus ceruleus, we have the superior salivatory nucleus, which is located in the brainstem, and then we have the magnus raphe nucleus, which is again located in the brainstem, particularly talking about exactly it is located in the pons. So these are the different locations of the nuclei which are lying over here. The pathway of the pain that is carried out in this particular pathophysiology is when these vessels that are basically the blood supply towards the dura mater, they are vasodilated due to any mechanism that is going to result in the sensitivity of this pathway to be increased, which is basically leading towards the salivatory nucleus involving the brainstem nuclei, particularly the locus ceruleus. It then goes on to the contothalamic tract and enters the thalamus and the hypothalamus, and then obviously towards the particular pain receptive areas of the cortical region. So this is the particular pathway. The main nuclei which is involved over here is the trigeminal ganglion. So this trigeminal ganglion is very important, and it plays a very significant role in the underlying pathophysiology of the migrainous activity. We have the sphenopalatine ganglion, which is prior to the trigeminal, which is present prior to the trigeminal ganglion. It is present in the pathway as well. So this is the major pathway which is responsible again for the development of this painful condition. The pathogenesis and the factors which are responsible, we can consider a genetic consideration over here. More than 38 migraine-associated genes are present, and it's basically a polymorphic condition that we usually observe. The environment plays a very important role as the triggering factors over here. The barometric pressure, the stressful conditions, or the exertional states are again the conditions which can trigger the condition of the migrainous activity. Metabolism is very important. People on diet, people following a very strict diet usually present to you with these kind of conditions. We have the neuroendocrine functions, particularly the involvement of hormones. Menstrual cycle is very important. Pregnancy can precipitate the condition of migrainous activity in the individuals. Certain drugs, for instance, we have the exacerbating medications involving the hormonal contraceptives, or females who are taking the estrogens are usually more prone to the development of this migrainous activity. The brainstem activation is the major pathway involved over here. We have the hypothalamic activation, and all of these, the brainstem as well as the hypothalamus, when they are activated, it results in the release of the CGRP and the PACAP enzymes or the hormones that are secreted as a result of this activation, and they are basically pretty much involved in the development of this migrainous attack. The usual symptoms that the patient would be having is the nausea. The patient would complain of photophobia and lightheadedness, or which is also termed as vertigo. We have scalp tenderness, which is noted down by a lot of individuals. We have nausea, vomiting. These are the particular conditions that the patient would be suffering from, either in the period of the aura or after the headache has even settled down. The patient would be giving you the history of this particular set of symptoms. We'd be experiencing that the patient is also having visual disturbances, spectrum of light, flashes of light, as well as the patient can also complain of paresthesias in certain areas, particularly involving the limbs. Vertigo, dizziness is a major sign and symptom over here. Photopsia, basically having the blurred vision is again very important. Having the visual disturbances is very important over here. Even in a lot of individuals, they would complain of particular floaters in the visual field, and this is a very important sign in cases of migraine. The alteration of consciousness is again one of the major sign over here. Visual disturbances, then we have paresthesias, and then we have vertigo, photopsia, as well as the alteration of consciousness, as we even went through over here. Then we have the GI disturbances, particularly as we mentioned, the patient is going to have nausea and vomiting that might be associated with episodes of diarrhea. There can be a fortification spectra, seeing different colors of light. Syncope, feeling lightheaded, is basically known as the syncope, or even it can be a state of unconsciousness observed in the individuals. In complicated migrainous conditions, the patient also suffer from seizures. So this can be the seizure activity is seen in a lot of individuals, but it would be only seen in the complicated states. Confusional state, so the person would be not quite oriented in time, place, and person. So these are the particulars that we'll be focusing on. Diarrhea, fortification spectra, syncope, seizures, and confusional state as we went through. So the diagnostic criteria, how do we diagnose that this particular person who reported to you with headache can be termed as having the migrainous activity? This is not as we just simply define the condition to be episodic and recurrent, and we cannot simply label a person to be suffering from a migrainous activity just on the basis of this particular sign, symptom, or the episodic or the throbbing headache that the person is having. The particular criteria would be if the person is having repeated attacks of lasting for 4 to 72 hours, the patient with normal physical examination. So it is a rule that the patient should have a normal physical examination and no abnormalities in the vitals. With at least 2 of these conditions, that is, either it can be a moderate or severe intensity, the pain has to be unilateral, aggravation by movement, and throbbing nature of the headache. So it can be either 2 of these conditions to fulfill the criteria or to match the criteria for the migraine. Plus, at least 1 of these conditions, the patient should or must have nausea and vomiting, photophobia, or either phonophobia in this particular state. So this is the particular criteria that we have to follow when we are diagnosing a case to be definitively of the migrainous activity. Imaging is very important again over here. We perform a lot of imaging techniques. For instance, we resort to CT scanning. We perform the PET, that is the positron emission techniques over here. And we'll be focusing on, as you can even see over here in this positron emission technique tomography, that is the PET, that there is an increased activity for the gray matter. So in different patients, different cortical regions can be observed for this positive gray matter activity is increased in these patients, and that can be only visualized when we carry out these radio imaging techniques and diagnose that this particular person is either suffering from the migrainous activity or not. So these are the PETs that are basically showing the increased gray matter activity either in the brainstem, either in the thalamus, or in the hypothalamus, respectively over here. Again, these are the different cross sections that are focusing on the gray matter activity, and sometimes this increased gray matter activities, that is why associated with the seizural activity that is also noted down in the individuals. Then we have the non-pharmacological treatment. A healthy diet is very important that you have to maintain in these individuals, and you would educate the patient that if he or she focuses on having or consuming a healthy balanced diet, it would basically help in preventing the migrainous attacks. You'd ask the patient to have regular exercises. Regular sleep patterns are very important for these patients, and the sleep cycles are not to be disturbed for these individuals. What are the don'ts for these individuals? We have to basically educate the patient and take the history in detail, and that would basically highlight the trigger points for the particular patient. You have to prevent the individual from these kind of headaches by preventing the triggering factors. Excess caffeine and alcohol has to be prohibited. Acute changes are also seen in these individuals. And then we have the pharmacological treatment. We resort to the pharmacological treatment only when the non-pharmacological techniques prove to be of no value in particular patients. So the treatment can be even by simple analgesics. And for instance, we have aspirin, we have caffeine. We can also prescribe the patient with NSAIDs in this particular patient. Naproxen is one of the drug of choice in these individuals that we can resort to particularly. Then we have ibuprofen. We have 5-HT1 receptor agonists, particularly oral, either it can be ergotamine, naratriptane, and then we have the nasal drops. For instance, we have the dihydroergotamine, we have the sumatriptan, and then we have the zolmitriptan. So these are some of the nasal drops or the nasal drugs that we can prescribe for these particular individuals, and they have proved to be very beneficial in these individuals. Parenteral drugs are sometimes also given as one of the serotonin receptor agonists in these cases. The dopamine receptor antagonists would consist of the oral drugs. We have the metoclopramide, particularly we have the chlorpromazine, and then we have the nasal drugs, namely the butorphanol, and the parenteral drugs would include the opioids over here. So this is the list of drugs that we can resort to, and sometimes we can also combine the non-pharmacological treatment along with the pharmacological treatment. So this is basically it depends upon person to person what the person is responding to or what the patient is positively responding to in a particular case. So you would manage the case accordingly in this particular case of migrainous activity. The preventive measures are to be taken. Whatsoever the case is, the drugs usually given for the preventive treatment are pizotifen. Then beta blockers is one of the important group of drugs which can be given as a preventive measure in cases of the migrainous activity. Namely, we have propranolol, we have metoprolol, and the antidepressants are also included over here, which include the amitriptyline, which is one of the most important and significant drug out here in this category. We have the dosulapin over here and the nortriptyline included in this group, and the venlafaxine is also given in some cases. Another group of drugs includes the anticonvulsants. It is one of the therapies that we can resort to, including the topiramate, valproate. The serotonergic drugs would include methysergide, and the other classes includes the flunarizine, candestartin, and chronic migrainous activities can also be treated with onabotulinum toxin type 1. So it is kind of a botulinum toxin that was given initially as a research drug, and it proved to be quite beneficial in chronic migraines. No convincing evidence from the control trials are given, but we can prescribe some patients who are not responding quite well or who are exhibiting a series of side effects with the other group of drugs. We can prescribe verapamil as well. Control trials demonstrate no effect. The drug included in this category is nimodipine, which is basically a calcium channel blocker. So these are the different group of drugs which we can resort to when we are treating the patients of migrainous activity. Clonidine, selective serotonin reuptake inhibitors and inhibitors, fluoxetine, they prove to have no effect at all on the individuals with the migrainous activity, but still researches are going on for this purpose. Having done with the migrainous activity, we have the other kind of primary headaches known as the tension type headaches that we have to deal with in a lot of individuals. So the classification over here, including the tension type headaches, would include the infrequent episodic tension type headaches in the individuals. Then we have the frequent episodic tension type headaches, and then the chronic tension type headaches. So the personality over here is very important. Taking the history in detail is very important. Usually people having a type A personality would undergo these kind of attention type headache. The band-like phenomena is observed involving the occiput as well as involving the lateral temporal areas. And these are the particular sites for the development of the tension type of headaches in the individuals. So the sign and symptoms are going to be looked for. The clinical features would include nausea. Photophobia is sometimes seen in these individuals, and the pain is aggravated with movement as well. The associated symptoms would include vomiting, photophobia, seeing flashes of light, and photosensitivity is observed in these individuals. Osmophobia, having flu-like symptoms, rhinorrhea, is also sometimes associated with this tension kind of a headache. The nature of the headache is usually throbbing, and the intensity is very severe in these individuals. The treatment would again depend upon the condition of the individual. Either we can resort to the non-pharmacological treatment, or in the other cases, we can also resort to the pharmacological treatment. That would consist of mainly the analgesics. Then we can resort to NSAIDs, and behavioral approaches. Counseling sessions are usually conducted with these patients just to have a better outcome. Relaxation techniques are also practiced for these individuals, and amitriptyline is a drug of choice over here as well. So amitriptyline is one of the drug in which can be used even in cases in which you're confused either to sort them out as a tension type of headache or a migrainous activity. You can always resort to giving the amitriptyline, which is an antidepressant. So over here in this particular lecture, we discussed the primary headaches. Mainly, we have the migrainous activity, and then we also went through the particular clinical features and the management guidelines of the tension type headaches as well. So that is the end of this lecture. Thank you for watching sqadia.com.